Okay, thank you for coming. The session on materials, material sciences in nanomedicine. I'll be the first speaker. It's a very dense session. It's actually 7 talks, so we will be very quick and sharp, and we will take only burning questions at the end of each talk. So my name is Paolo Decuzzi. I'm located right now in Genova and in the Italian Institute of Technology. You can sit next here or you can actually sit in the audience. Doesn't make any difference to me. And I'll be talking about mostly polymeric nanoconstructs for drug delivery and biomedical imaging. So the lab historically has not been working only on a single specific nanoparticle, but it has been playing, let's say, with particles of different size, shape, surface properties, and more recently also we have been changing the mechanical stiffness of these particles. And you will see throughout the talks that there is a strong reason why we have been looking to these 4 different parameters that we call the 4S parameters. So small nanoparticles, nanocube and micelles, very small, 20 nanometers. Then the conventional nanoparticles that we call spherical polymeric nanoconstructs, the discoidal polymeric nanoconstructs in the size of 1 micron or so. These are similar to platelets. They actually tend to work like platelets. And then a number of systems that I'm not going to talk about, but they are actually displayed in the posters. So I'll tell you a few stories in the next 6 minutes or so regarding the spherical polymeric and the discoidal polymeric nanoconstructs. I don't have to explain the EPR effect, of course, but I would like to capture your attention on this image here that basically presents the nanoparticles as a multitude of drugs that are loaded inside, a multitude of agents, contrast agents that can be co-loaded with a nanoparticle. So the intrinsic multifunctionality of nanoparticles. Over the last few days, I haven't seen many particles that were truly multifunctional and truly combinatorial in terms of drug delivery. Most of the nanoparticles were actually delivering one single agent. And I think that there might be a reason that is related to approval and the translation into the clinic, but actually we are missing a number of opportunities there. We have to leverage that. And so the first thing that I would like to discuss with you very briefly is the opportunity of co-loading within the same nanoparticle a chemotherapeutic drug as well as a drug that is anti-inflammatory. In this case, a natural drug like curcumin, a natural molecule like curcumin. And when you do something like that and you inject that into mice, you immediately realize that, compared to the free docetaxel, at a dose that is very low compared to the clinical standards, the nanoparticles loaded with docetaxel and docetaxel curcumin, they actually behave better. But what is even more interesting is that the combination of curcumin and docetaxel, basically after 3 months of follow-up, doesn't show any recurrence of the disease. So there is clearly a synergy between curcumin and docetaxel, but we have shown it also in the case of diclofenac, and we're working on celecoxib. So message is combination therapies using anti-inflammatory drugs and chemotherapeutic drugs, and somehow having an efficacy not only on the tumor cells, but also on the tumor microenvironment. Now, another thing that is very interesting is that when you quantify the accumulation of these particles in the tumor at the beginning and after treatment, the particles are still getting into the tumor. The accumulation doses are 4 or 5% of the injected dose. So these are somehow in lines with what has been published, what has been shown also yesterday, but very low, in my opinion. Now, the same nanoparticles, another beauty of nanomedicine, now loaded with methotrexate, they get into the plaques of ApoE mice that have been fed with high-fat diet, and not only that, they actually are able to limit the growth of the plaques. Same nanoparticle, we just change a drug. We use a drug that is being developed in the 40s, so very old drug, still has an efficacy. Very low accumulation doses also in this case. Same nanoparticle, we change the drug, we load dexamethasone, we inject it into animals that have been administered with DSS, so basically they have been developing this inflammation in the bowel. The particle, they still get there in a disease-depending fashion, so the longer is the treatment, the more they get there. and they actually tend also to cure the animal and reduce the inflammation. Same nanoparticle, 3 different diseases, we're just changing the drug, they are getting to the point, they are doing what they are supposed to do, but the loading efficiency of these drugs into the nanoparticle is very low, not even 10%. And the accumulation is also very low. So there is clearly something that we can do. It's working, the system is working, there is no question about that. The system is working preclinically, of course, but there is clearly something that we need to do in order to improve the efficiency of delivery. So we have been talking about accumulation, right, yesterday. So there is a lot that can be done in order to improve the accumulation. And I think it's not, of course, a sufficient condition for being therapeutic effective, but it's clearly a necessary condition. And so this is the reason why over the last few, I would say 1 year and a half since we moved from Houston to Genova, so starting up all the laboratory again, we have been working on these discoidal polymeric nanoconstructs where we can actually change the size, the shape, the surface properties. We were, together with Joe De Simone, probably the first group in 2006 to start working with non-spherical particles. And now, not only that, but we can change the stiffness. So now these particles are actually deformable just like cells. Not only we can modulate size, shape, surface properties, but also the stiffness. So they are deformable like cells. Some of them, some other are rigid. And what are the advantages of this? Well, you know, if they are deformable, and we're not the only one, but there are another 3 groups in the world that have been publishing this over the last couple of years. Some of them are on ACS Nano, some on other journals. But basically, if they are deformable, these particles, which are 1 micron in size, so way bigger than what we consider usually nanomedicine, they circulate for over 24 hours. Circulation half-life of the order of 20 to 24 hours, okay? Just because they are deformable, they can make it through the smaller capillaries in the lungs, in the spleen, and so on. And there are other things about deformability that I will show you. And if they are long circulating, eventually they get into the tumor, they stick or they somehow get trapped into the fenestration of the hyperpermeable tumor vasculature, and they reach concentrations of the order of 20% of the injected dose per gram tissue. We can do better. I'm pretty sure that we can do better. Again, this is not efficacy, but if you don't have accumulation, there is no way that you can get any efficacy. Okay, it's a necessary condition. We are starting from a few percentage points, 1, 2, 3%. Let's get 20, 30, 40%. Can we make it? I think if we can make it, that will be a dramatic change in the way we are with nanomedicine approaching a number of diseases. Now, same nanoparticles. What happens in the liver, in the RES organs? If they are rigid, they get trapped more than the deformable. They can actually evade significant accumulation into the liver, into the spleen, into the lungs. This is an healthy mice. This is an healthy mice, so particles don't know where to go, they circulate. In a tumor, the situation is way different. You got more in the tumor than into the, you got more into the tumor that are actually soft rather than into the, let me go back here. You got more in the tumor, if I can get back, let's see. Yes. Take some time. You got more soft particles into the tumor rather than the rigid nanoparticles, because the rigid are getting into the liver, okay? Now, why is that? Well, if you look at this slide, here we're moving with the stiffness, here we're moving with the size. And these are bone marrow-derived monocytes, primary monocytes, okay? If you incubate them with stiff particles or larger particles, you can actually see that clearly. The stiffer the particle, the more they get internalized. The softer the particle, the less they get internalized. So again, the concept that if you work with soft particles, they circulate longer, they're not easily sequestered. And there is more to that, of course, quantification. But one thing that is emerging is that the soft particles, they actually spend less time in contact in the vicinity of the bone marrow-derived monocytes. They get closer, but they cannot be engulfed by the bone marrow-derived monocytes. With the rigid particles, that's exactly what is happening on a much shorter time period. So we're still working on this because there is a lot that can be done, I guess, again, in trying to avoid the sequestration by the RES system. And then we have been working with these particles on different tumors. The one that I showed before were melanoma and glioblastoma multiforme. Here we're looking at breast cancer, both orthotopic and metastatic. Of course, it's fluorescent, so it's, it's not really quantitative. We're now working with ICP-MS and doing GAD, as well as copper-64 and nuclear imaging in order to really quantify. But if you look at this preliminary data, it's quite encouraging, it's extremely encouraging. And I guess, again, that we're going to reach about 20–30% most likely of the injected dose per gram tissue. And in the same particles, you could actually do a number of things with lipid conjugates, lipid GAD, lipid drugs. You can actually use these systems as very effective delivery systems. And I think my time is up already. A good portion of my group is sitting there. I will ask them to stand up, and we can clap all together. Thank you for your attention. If there is any burning question, I'll take it now. Otherwise, we'll meet outside, in a good sense. Yes, Avi, you remember that we are friends.
So, great talk. I did want to ask about the configuration of different particles and looking at round particles, which many of us use, and actually changing to new configurations. What's your insight on that? You touched it here, especially when the tools that are actually available today for trying to change an aspect ratio, for example, in nanoparticles, are still limited.
So we have been working for, I would say, as I said, together with Giulio Simone, we have been probably the first in 2006 to go out and publish papers on non-spherical particles, right? And the rationale for that is that non-spherical particles are way more effective when they have to circulate into the vasculature, and somehow it has been shown also that when it comes to internalization, non-spherical particles, they might have some advantages in resisting internalization, right? And so the discoidal shape comes exactly from that idea, having something like an airplane that can navigate with the red blood cells, stick to the vasculature, or get trapped, if it is deformable, into the openings of the tumor vasculature, and then do whatever is needed. Release from a perivascular location, basically your drug and your cargo, right? So I would say that the spherical particles are suboptimal when it comes to circulating into the vasculature. They are clearly optimal when it comes into internalization into the cancer cells, because the spherical shape is way better than others. Maybe the rod shape can only beat it. And so the game is, right, working at the interface between these two configurations. And having a particle that is deformable gives you additional latitude for exploring different solutions. I don't know if I have addressed the question, but we can continue talking about that later on. Okay, I don't think that we have time for a second question, so I will invite the second speaker.